So older adults commonly have mental illness, and we know that this number is expected to increase in 2030. Also, individuals with dementia may experience behavioral and psychological symptoms, and we often prescribe psychiatric medicines for them. Even if it's not antipsychotics, it can be antidepressants, mood stabilizers, etc. And so we're likely to see more of this, and we're also likely to see more challenges with these medicines when we're using more than one psychiatric medicine. So this is just a brief table that looks at folks living in community settings and the amount of office visits based on age and related to a medication they may be taking. And so even though the use of these medicines is less in the older adult population, you can still see the number of office visits that occur in a year related to them. So it's rather significant. And with the highest ones being related to antidepressants and anxiolytics. And when we look into the long-term care setting, we know that psychiatric medicine use can be as high as 70%. And again, not just focusing on antipsychotics, but any psychiatric medicine. And use of these medicines is more common among women, individuals who are living with dementia, those who are functionally disabled, and in long-term care facilities that have low levels of RN staffing tend to use more psychiatric medicines. And this is, I'm kind of preaching to the choir here. We know that older adults are more susceptible to challenges with their medications. And often we have very little guidance because they're often excluded from clinical trials, which makes application to an older, frail population more difficult. Also, there are changes in terms of metabolism and excretion as we age, issues related to multimorbidity and drug-disease interactions, as well as drug-drug interactions, and lots of polypharmacy with our older adults. And so all of this leads to an increased risk of adverse drug events. So we're going to start with a little case, of course. And this is Mrs. G. She's an 83-year-old married female. She has a long history of major depressive disorder and more recently in the past 3 years developed vascular dementia. She's living at home with her husband and she has family that lives nearby. And functionally, she's able to perform her activities of daily living with some encouragement and cueing and things. She ambulates with a cane, and she can actually help to prepare some simple meals with supervision. And she can verbally communicate effectively, and she's really mildly impaired cognitively. And her medical history is notable for hypertension and hyperlipidemia, coronary artery disease. We already mentioned the vascular dementia. She has insomnia and a history of low back pain. She does have a history of tobacco use, though she currently doesn't smoke, and you can see her medicines including aspirin, atenolol, lisinopril, atorvastatin. She's on fluoxetine, which is Prozac, 60 milligrams, which is probably a little higher than we're used to seeing, and trazodone for that sleep disturbance, also probably a higher dose of 150 milligrams, and acetaminophen twice a day. So her outpatient provider receives a call from the patient's husband and says, Mrs. G's had a stroke and has sustained some left-sided weakness, and she was hospitalized and is now admitted for a post-acute stay. And he's concerned about her and just basically wants to notify the outpatient provider. She also, in the context of all of this, has been having increased low back pain, and at the post-acute and long-term care facility, she has a PRN order for tramadol that got actually started in the hospital but continued there. And he tells the provider that the symptoms she's experiencing now are she's much more confused, she can't stand and walk, she has these unusual intermittent jerking movements of her limbs, particularly her legs, and she's agitated and irritable. has some tremor, and the staff are saying that they're, kind of monitoring her heart rate closely because she has periods of tachycardia. And so the outpatient provider is concerned enough and calls the nurse practitioner who's caring for Mrs. G in the rehabilitation center and confirms that, yes, indeed, the patient is experiencing these symptoms that the husband reports, and that lab tests were done, including a CMP, a CBC, et cetera, and some urine, and everything is normal. She was previously treated for a UTI. And so the question is, are any of the psychiatric medicines causing these symptoms? So, and what do you think? So this is an example of a case of serotonin syndrome. So serotonin syndrome is potentially life-threatening, and it's caused by an excessive serotonergic activity within the central nervous system. And it's uncommon, but it does happen. And the three classic symptoms of serotonin syndrome are mental status changes, which you saw with all the confusion and agitation and things, autonomic instability. So these are kind of fluctuations in terms of increased heart rate, increased blood pressure, change in thermoregulation, as well as neuromuscular hyperactivity. And so she was having those episodes of myoclonus and that extreme stiffness. So what causes serotonin syndrome? Often it's caused by additions of medications that lead to more of a serotonin surge. But interestingly enough, it can happen even with just one agent. So you don't always need to have multiple agents. So keep that in the back of your mind. And it can emerge from overdose. So if somebody takes an overdose of their SSRI, or it can also happen with therapeutic doses, and as I mentioned before, with single agent use. So always keep that in the back of your mind. And now that we all have EMRs, I'm sure whenever you have somebody on 2 agents that impact serotonin, you're getting those little warnings are popping up. And a lot of people are like, yeah, ignore it, but always think about it if you're seeing sudden changes in your patients, and they could have been on these medicines and been stable, and then for whatever reason something changes. Okay, so this is important to kind of think about because it will help you to remember the symptoms. There is the 5-hydroxytryptamine receptors that are in both the central nervous system as well as in the peripheral nervous system. And so the ones that are in the central nervous system help to control attention, cognition, behavior, memory, and then our temperature regulation. Whereas the peripheral ones affect GI motility, uterine contraction, that vasoconstriction, as well as bronchoconstriction. And then this is just a little graphic to show you the mechanisms of having this increased serotonin surge, and how there's a bunch of different places within the neurons that this can happen. So for example, tryptophan is kind of the substrate for which we get serotonin from. So there can be more tryptophan available. There also can be blocking of increased release of serotonin from into the synaptic cleft, and then blocking of receptors so that you're keeping more of the serotonin in that synaptic cleft. And all of that can result in increased levels of serotonin and put the patient at risk for serotonin syndrome. These are common medications that are associated with serotonin syndrome, and you'll see on the far right-hand side, the mechanism of action shows you that where they're working on that previous diagram. By far, the most common one is the serotonin reuptake inhibition, which happens with most of them. But there are other factors there as well to consider. And when we think about some of our older patients, particularly those with dementia or history of psychiatric disorders, a lot of these medicines are looking kind of familiar. So we're commonly looking at the SSRIs, but if we have someone who has migraine issues, we have to kind of take that into consideration. Also, the anxiolytics, a lot of people feel that buspirone is kind of minimal side effects, and it is, but it also impacts serotonin. So if you have somebody on buspirone and an SSRI and some trazodone for sleep, you may accidentally push someone into a serotonin syndrome.